like to welcome Dr. Hardik, our very young dynamic ophthalmologist who did his training in pediatric ophthal and neuro-ophthal from SSCI and LVPI. He'll be giving us a case presentation. Over to you, Dr. Hardik. He's very much interested in innovations.
Thank you so much, Dr. Nidhi. So I'll be quickly presenting a case where we just got away with the nick of a double-edged sword. My case is titled as a typical bilateral optic neuritis with a severe steroid toxicity. And this case was quite challenging to manage. So we had a young male, 21-year-old from Maharashtra, who complained of sudden bilateral painful vision loss since last 1 week. He had some pain on eye movements, which eventually subsided by the time he presented to us. There were no other symptoms that were corroborating with his current presentation. There was no history of any systemic prodrome prior to vision loss, no history of any neurological deficits. One important thing to note here is that about 9 years back, he had an episode of typhoid. 1 month later, he had vision loss, details of which are not known. There is no known documentation. He was admitted and somehow the vision came back, probably spontaneous recovery, or he was treated at that point. This is when he was around 12 years. Coming back to our present date, he presented with he had right eye blurring of vision. In a day and a half, his left eye had a blurring of vision. And on day 4, he started having pain around his eyes. On day 5th is where he sought a medical intervention. And that's where somebody diagnosed as possibly retrobulbar optic neuritis decided to get an MRI and sent and referred to us for further management. Now this is the clinical picture of the child. He is a hefty 115 kg, huge built boy with presenting vision of 23/20, which did not improve over the last 1 week. Both eye color vision was impaired and the pupil was sluggishly reactive. EOM was full, free and painless when he presented to us. Disc did not show any signs of disc edema. However, if we note, there is some amount of pallor that does exist in the neuroretinal rim. HVF, he was barely able to perform. He had a lot of false negative errors, but we can clearly see that there is some field loss that is there in both the eyes. Here is where things start becoming interesting. MGCL is thinned out. RNFL is also thinned out. Now, these are not the values that we would expect for a 21-year-old guy. We did an MRI brain and orbit. Contrast was not done, and because the primary doctor did not probably think of a typical optic neuritis needing a contrast per se. But we can clearly see that there are T2 hyperintensities, long segment, probably involving the whole length of nerve, more than 1/3 of the segment. With that, we also had the provisional diagnosis of retrobulbar optic neuritis with possibly an atypical presentation because of the age, the way in which it had presented, and we decided to go ahead with IVMP for 3 days. Blood workup was sent. He was double seronegative for aquaporin and NMO, and 3rd day is where he gave up. He told, now I can't take steroids any further. We decided to switch to oral steroids because that's the general course that we take. But on day 4, day 3 itself, he had shown a significant vision improvement. By the time he barely finished his IVMP, he had severe rashes, boils on his skin, hematochezia, bloody diarrhea. That's where we decided to send for a physician review, and the physician immediately discontinued steroids, and on supportive treatment only, he recovered, just letting the steroid effect go away. And on 1 month when he came back to us, he was 20/20. Now here is where, what if things would have got wrong? What if we can't give steroids? How do we treat with double seronegative cases? And if at all there is a recurrence in future, what do we do? Because we know that he can't tolerate steroids now.
I think you have presented a case of MOG optic neuritis. Other than the blood test, rest all is fitting into MOG optic neuritis. There was anterior visual pathway involvement, long segment is there, bilateral, sudden decrease in vision. A lot in the whole thing suggestive of MOG optic neuritis. Now, what kind of test was used to look for it was cell-based, fixed cell-based assay was done. It is, it's like one of the best ways. It wouldn't have been live, it would have been fixed cell-based assay, right? So it's come out to be negative. You would call it a double negative. Now, you can miss even on this the MOG optic neuritis, or you call it double negative optic neuritis. You can give high dose oral steroids. What the patient was not tolerating right in the beginning was the intravenous methylprednisolone. I think for Dr. John Chen's group from Mayo, they are suggesting you can do this pocket steroids, especially for MOG optic neuritis, oral steroids, you keep it, because oral steroids work, and high dose of oral steroids, that is what, immediately, instead of giving a prolonged treatment with IVMP, you just give immediate steroid. That's what can be done. But if it is actually behaving like MOG, to prevent recurrences, rituximab, mycophenolate, azathioprine, all these things I have seen in my cases, though have been suggested, they don't really work that well. I know you are in a problem, and many of the patients, they do not, you cannot wean them off steroids, and they develop severe toxicity to steroids. So a lot of monoclonal antibody studies are going on with that, but tocilizumab has been tried for these cases. If you really want to, with a rheumatologist's help, you can probably try tocilizumab.
Thank you so much, Dr. Shikha.
Can I just make one additional point?
Yes, ma'am.
I think when you're pushed to the wall, try IVIG, try plasma exchange. Optic neuritis is optic neuritis. And you have many other antibodies like CRMP5, which we do not do routinely. So when pushed to the wall, I think I would have preferred, of course it's steroid responsive, but IVIG and plasma exchange. Yeah, Rambans.
Thank you, Dr. Asta. Thank you, Dr. Shikha.